Hi, I'm Dr. S Ramesh, Chief Cardiologist at GM Group of Hospitals, Bangalore. Today in cardiology, we are facing two challenges. One, there is increased incidence of cardiac diseases, and what was earlier thought urban phenomena, now we see is also increasing in rural areas. Second aspect of this is that the number of doctors or the ratio of doctors to the population, especially in the rural areas, is very low. So we have this dual challenge of increasing incidence of heart disease, at the same time availability of medical facilities to treat these patients are low. In the beginning, telecardiology involved simple video conferencing. So whereas through video, the doctor would interact with the patient or the family physician and try to diagnose the problem and advise the treatment. But it has its challenges because one cannot fully examine the patient or cannot accurately detect the problem. Second was also this facility was not available everywhere because this involved a good network or connections which were not possible those days. So it was very limited and became more a fashion rather than actually being much use for the patient care. Subsequently, with increasing the mobility of our the mobile infrastructure in the country, this has overcome. Now, through the phone, one can interact, and you don't require a very sophisticated, computers and others to really do a video conference. But we have gone much beyond that. In the true sense that when a patient has a problem in the remote areas, we have various methods now to diagnose. For example, one of the major things that has happened is by ECG. Now, ECG earlier had to be taken physically with a machine, and then physically it has to be transported or shown on the picture, which has its own limitations because the consultant at that time may not be available to take the call, or the facility again may not be there in a really interior places. So now we have this tele-ECG, wherein there is an inbuilt mechanism with a network wherein one can take an ECG in a remote area, whether through a doctor or a technician, somebody can take an ECG. The cardiologist from the other end can view the ECG through the phone or the other means and immediately give an opinion whether the ECG is normal or abnormal. This has made a tremendous progress because earlier, first of all, many places did not have a ECG facility. On top of it, even if you take an ECG, most of the time the family physician or the nurse or whoever takes the ECG did not have or do not have the knowledge or the wherewithal about diagnosing the problem. So invariably it involved, though ECG is taken, the patient has to come to a consultant place and show the ECG. And the patient many times had to wait for hours for a consultant's opinion. This involved considerable delay and the cost. Because if the ECG is normal, unnecessarily patient had to travel a long distance, wait, and almost whole day just to say that his ECG is normal. If it is a acute MI or something, then again there is a delay because by the time somebody sees the patient, it could be very late. Now with telecardiology and this tele-ECG, it has become very easy that in a fraction of a second or a minute, we can diagnose the problem, whether it is normal ECG or abnormal ECG, right at the doorstep of the patient. Somebody can set up go to the patient's house if he has chest pain, take an ECG, immediately send it across. I mean, that has become a big advantage now because the network is so well done now, even the remote villages are covered by the net, and thereby it becomes very easy to transmit. Now, telecardiology has gone beyond that also now. Apart from the ECG, now even echo, one can transmit the images from a similar box and send it across. We actually did an experiment further. We, as I said the adage earlier, if patient cannot come all the way, we even had a so-called mobile cardiac cath lab, wherein the cath lab would go to the doorstep of the patient, and thereby we can do angiogram literally at the doorstep of every patient. Of course, in our prototype model that time, it was a little bigger machine, bigger trailer. So we couldn't really take it to the remote villages, but with advancement, with the reducing the size of the cath lab, with a smaller trailer, we can go to the interiors of India and can do procedures like angiogram and angioplasty. Similarly, same kind of facility now available for laboratories. You can do blood tests at a different place, at remote areas, and then transmit the reports. We have there are places where they do this kind of a CT scan in the rural areas and send the images to the radiologist. So telemedicine or telecardiology has now gone leaps and bounds, so that we will be able to deliver the care. And now, of course, we have also so-called robotic angioplasty or angiogram, wherein an expert can sit in his office at the same time in a remote area he can operate and do an angiogram and angioplasty. As a first step to reach this goal, we at GM Hospital, Bangalore, have started a tele-ECG facility, so that we will be keeping ECG machines in different parts of Bangalore and at family physicians level, so that they can take ECG, immediately send it to us. We have done a test trial. Within 2 minutes, the ECG can come to the cardiologist, and less than 5 minutes, the diagnosis can be made. We have already done, and we have started this project, and we expect at least in the next 1 year, we reach out to about 100 family physicians this way.